All right, and we are recording. Thank you everybody for being here today. I'm Chad Coulis, Executive Director of the Midway Chamber. We're very excited to have our guest today. Just a quick reminder, please stay on mute. And if you have any questions, you can ask them in the chat. We're gonna get to as many of them as we can. And now I'll do a quick introduction. Dr. Michael Osterholm is one of the leading researchers in infectious disease and is an international leader on the critical concern regarding preparedness for an influenza pandemic. He is the author of the 2017 book, Deadliest Enemy, Our War Against Killer Germs, in which he not only details the most pressing infectious disease threats of our day, but lays out a 9-point strategy on how to address them, with preventing a global flu pandemic at the top of his list. Please welcome Dr. Michael Osterholm.
Thank you very much, Chad, for the opportunity to be with you today. I'll spend a few minutes just giving you a background update on where we're at, and then hopefully get to your questions and answer those. I'm sure you have many pressing ones, as we all do. When you talk about the concept of a pandemic, you're talking about a worldwide epidemic of a disease that basically puts everyone in the world at risk for acquiring that infection. The pandemics that have been of great concern over the history of humankind have been those caused largely by the respiratory tract, meaning those that are by breathing air that you share with someone else. Those tend to be the most dynamic, and over the years have been the killers, whether they be influenza or smallpox, in particular pathogens like that. We've been concerned about influenza pandemics because, in fact, we have a history with those over the past 250 years. There have been 8 for certain and likely 10 such pandemics that have occurred. And each of those were situations where a new virus evolved out of a bird population and no longer was a bird virus, but became, through genetic changes, mutations, able to infect humans, and humans transmitted around the world. Of those 10 influenza pandemics, they've all occurred at different times of the year when they started. 2 started in the Northern Hemisphere winter, 3 in the spring, 2 in the summer, and 3 in the fall. And in each instance, one of those, there was a first wave of illness that occurred throughout the world, but it was sporadic, meaning that you would see some cities, for example, in the United States, hit and other cities not. 1918 was a classic example where you had cities like Chicago and New York that got particularly hard hit. Other cities in the same regions did not. And then for also unexplained reasons, the virus would basically just tail away, not because of human behavior change or anything we did. It would literally, in a sense, disappear. We don't understand why that happened, but it then is quiet for several months, and then all of a sudden it tends to come back. And the second wave is much, much larger than the first wave. They tend to be geographically universal across the world, and these are the ones we really fear. Well, this is what we were planning for. 1918 was an example of a very severe one where, in fact, over up to 200 million people died at a time when the world was just 1/4 the size it is today in population. To give you some perspective on that, even though the influenza pandemic was only there present in World War I for the last 3 months of the war, there are 8 times as many young US soldiers buried in France from flu deaths than there are from the war itself. And so this has been a concern for some time. We've had subsequent pandemics in 1957, 1968, and 2009. They were not as severe, but did occur, did cause a lot of illnesses and deaths. And each one of those too had the same kind of pattern that I talked about. So I first wrote about this in the early 2000 time period and said, wake up world, these are going to occur again. We have to be concerned about them. Then along comes this coronavirus. Coronaviruses get their name because they're a virus that looks like a crown. There's spikes on it. If you actually see it in the microscope, it looks just like a crowned kind of environment. And in this instance, we've had a history with coronaviruses in humans that have come from animals. Most notably, there are several that cause the common cold that do have some seasonality to it, not that severe. There's one that also does cause pneumonia, but it occurs very infrequently. The 2 that we have been most concerned about that emerged from animals to humans was SARS, severe acute respiratory distress syndrome, that occurred in 2003 and originated in the Guangdong province of China. There were over 9,000 cases, 900 deaths worldwide. And for this virus, we had 2 things happen that allowed us to basically, in a sense, eradicate it, or at least eliminate it for the time being. One, we understood which were the animals in the markets of the Guangdong province that were spreading it. They were eliminated, so humans stopped getting pinged. And then in addition, we realized that humans were most infectious once they got infected only after 5 or 6 days of illness. Well, the same thing happened then with MERS, Middle Eastern Respiratory Syndrome, in 2012 when it emerged on the Arabian Peninsula. And in that situation, the animal actually happened to be camels, which were not going to be eliminated from the markets. And for that matter, not really changed in any way how they're going to interact with people. And again, with MERS, we saw that most of the individuals did not have really any level of notable infectiousness until in the 4th or 5th day of illness. So there we continue to have cases. And in that instance, it's more a matter of we're just not going to get rid of the camels, but we stop human-to-human transmission. When you take a step back right now and look at the idea of, well, does MERS seasonally get spread, et cetera? SARS did not. SARS ended because we figured out how to stop it and get rid of the animal reservoir. I've been very involved working on MERS on the Middle East. I've been outside a hospital in Abu Dhabi when it was 110 degrees and MERS virus is transmitting very well, thank you. So again, we don't have a sense that that coronaviruses automatically have to be seasonal. Well, then along comes this situation. Our center started tracking this in late December when we had the first inkling that something was happening in Wuhan, China, the major transportation hub in the center of China, located within the Hubei province. Wuhan itself has a population of about 11 million. The entire region, which is one continuous large city, has about 65 million people. And we saw this illness start that looked like almost like a SARS or MERS picture. And in fact, our first thought was in late December, early January, that no, this was going to be another SARS or MERS. We'll be able to control it just by basically identifying people early and isolating them so they don't transmit to others. But by the second week of January, it was clear to us that this was not another MERS or SARS, that in fact, transmission appeared to be very effective between people early in their illness, if not before their illness symptoms started, and that the respiratory transmission, very much like influenza, was very efficient. On January 20th, we put out a document that basically said, this will cause a worldwide pandemic. There's no way the Chinese can contain this. We had ample information from China by that time that in fact this was going to happen. So if you hear messages that somehow this was hidden, while the Chinese surely in December did not provide the information that at that time about what was happening, I have to honestly say it's probably not that dissimilar to what would happen in the fog of an outbreak here in the United States initially. But by early January, we were getting the information. On January 11th, the Chinese actually published the entire sequence of the genetic sequence of the virus so we could start building tests, even start working on vaccines. And in that January time period, we also put out that this was going to not only spread worldwide, but that because we now understood that it looked like the incubation period, or the period from the time you get infected until you actually get sick and are infectious, or just slightly before that, is about 5 days. And it looked like on average, people tend to infect about 2 people. So you go from 1 to 2 to 4 to 8 to 16 to 32. And it takes a while before you build up sufficient numbers of cases, particularly when a large chunk of them will have only moderate to mild illness, before the world would find out. So it wasn't a surprise to us at all. We predicted that late February, early March, we'd start seeing cases around the world, particularly in highly dense populations. Exactly what this virus did. It wasn't a surprise, nothing there, other than the fact that just watching what kind of illness it could cause. And so I want to give you that background because I also want to emphasize I'm at the end of my skis right now. At this point, we don't know what's going to happen next. A couple of points. This virus is very efficiently spread by respiratory transmission, this kind of aerosols, just breathing in a room. Today, all of us sitting in the rooms we're in right now, in the period of time that I've been talking to you, just breathing, you have created a perfume of aerosols in your room. And if I could light them up with a ultraviolet light, you would see what appears to be exactly what you see when you look at the sunlight coming through your window sometimes and see the dust floating that appears, oh my house is dusty. That's aerosols. And that's what you have with this particular transmission. Another way to look at it, when we open department stores and you're 4 aisles away from that department store, you will, or from that perfume area, you'll smell the perfume 4 aisles away. that's again an aerosol. So that's number one. This is a very efficient transmitting virus. Number two is the fact that to date, we estimate that no more than 5 to 20% of the US population has been infected. 20% is only in certain areas of the New York City metropolitan area. The vast majority of the United States is in the 5% range. And for that matter, most of the world is in a 5% range. Studies out of France, Spain, Germany, all in the last week have all demonstrated that about that percentage has been infected. Why is that important? Because this virus is operating under a very basic principle of basically physics, chemistry, and biology. And it responds to viral gravity, as I call it. This is going to keep trying to transmit to humans until at least 60 or 70% of humans have been infected and hopefully develop some kind of what we call durable immunity. And that means it's going to last for more than just a few weeks after you're infected and recover. And that's a long ways from 5 to 15%. So when you think about what this disease has done in terms of pain, suffering, death, and even economic disruption, it's only been for 5% for most of the country, and we're not going to rest until it gets to 60 or 70%. Now we can get there two ways. We can get there either through natural infection, or we can get there through a vaccine. At this point, I'm happy to address issues around the vaccine. I caution you about the happy talk that continues to occur about it. I more than anything want to see a vaccine, but it's not forthcoming in the days and weeks and even months ahead, as some people propose. There's a lot of challenges with this vaccine. We don't know if we can actually get permanent immunity or long-term immunity. There are safety issues with this virus in terms of what it does, and just the issue of manufacturing and distribution is going to be a huge challenge for something like this. So how are we going to get to that 5 or 15% to 60 or 70%? And then I want to emphasize, even at 60 to 70%, the virus doesn't stop transmitting. It just slows down. So, well, our center came up with a document that was published several weeks ago. I would urge you to go look at our website. If you want more information, it's www.cidrap.umn.edu, cidrap.umn.edu. And there's a document on there under the CIDRAP viewpoints on scenarios in which we've laid out. One is, this is a coronavirus. So again, as I said, I'm at the edge of my headlights or skis, and we don't know what it's going to do from here. But if it follows basic an influenza-like model, my biggest fear is that in the course of the next 3 to 8 weeks, we're actually going to see this virus just kind of go away, which seems so, inconsistent. How could I say that? It sounds almost amoral. Well, I surely don't want anyone to become ill. I don't want anyone to get seriously ill or die. But the bottom line, if it goes away, then it's telling me this is starting to act like a flu virus. And if that's the case, it's very likely we could have a major peak of activity late summer and early fall that would be, in fact, devastating. It could be. And so we have to entertain that possibility. That's one. The other possibilities are coronavirus, and we lay this out in this document, could be it's just as on a slow burn. It just continues the level it is right now. And as a society, we just figure out how we're going to live with this as well as die with it and move forward. And then the other one could be that we have the situation where we just have what we call kind of the foothills or the ups and downs, regional outbreaks that are not maybe as bad as New York, but they just keep occurring and occurring and occurring, but it's going to take us a long time. Previous pandemics like this took years, not months. And that's what I think people don't understand right now. That's what we're talking about, the potential here in terms of what we could be putting up with and how we're going to have to learn. As I've said, we unfortunately had to learn how to die with this virus. I can tell you, having had friends who have died, watching healthcare workers at risk and of dying, doing their job, this has been a very, very painful thing to learn about. But at the same time, we're going to have to learn how to live with it, because this is not going to go away. Anybody who comes away from today's webcast here with the idea that this is just get over the hump and get to summer, you didn't listen. This is not going to go away soon. And I say that in the context, again, I want to emphasize that it could see a big decrease in cases in the short term, but they could surely come back with a vengeance. So I think that's the one thing that we have to keep in mind. The second thing I would say is, how do we get through whatever months it's going to take if we do get an effective vaccine? And I look at the two guardrails on this situation as, one, we locked down like they did in Wuhan for 12 to 18 weeks, where nobody left their houses, but for one person every week to go out for an hour and get groceries under surveillance. You know, are we going to be able to do that? It'd make anything we've done so far seem mild. And I think we'd all agree that would not just destroy our economy, that would destroy society. We can't do that. It won't work, and it will be a challenge that the question would be, what have we really done? On the other side, the guardrail is we just can't let this go willy-nilly. If you think about this, in my career, I always feared this, but I hoped I'd never see it. Not since 1918 have we seen what's happened in the last 2 months. 80 days ago, this virus was not even in the top 100 causes of death in this country, not even in the top 100. For a better part of the last 5 weeks, this virus has been the #1 cause of death in this country. Cook County just did a review and announced yesterday, 55% of all deaths in Cook County, Chicago area, since January 1 have been due to COVID. That gives you some sense of the power and impact. And again, I just can't say it strongly enough. This is just getting started. This is just the warm-up. This is not the big harangue yet. So I think that that's what we have to understand as a society. We're going to be coming in and out potentially of serious challenges with this for some time to come. And I don't have any other way to say that. We can't let the healthcare systems go down because of this extreme number of cases that can come in for several reasons. One is just the care for the COVID patients. Number two is we put healthcare workers at risk every day. We're already still short of professional or protective equipment for these people, PPE. And if we're short now, imagine what we could be like if we have a big peak coming this fall. So we surely want to hold that down. The third thing is that we're looking at mortality data right now from a number of areas of the country that were severely hit by COVID, where people didn't die from COVID. They died from heart attacks, they died from strokes, they died from accidents, et cetera, where they couldn't get adequate care because the healthcare systems where they would have gone to were so overly burdened and directed at COVID care. So we all have a reason for not wanting these hospitals and healthcare systems to be choked up with this kind of situation. So let me just say at this point, what can we do about it? Testing is a very important issue. We're putting out a document tomorrow. However, testing has really been misunderstood. This mantra of test, test, test is terribly misdirected. You want what we call smart testing. We'll define that at some length in this document that's coming out tomorrow. And in that, it will talk about, we want basically the right person to get tested at the right time with the right test for the right reasons, and that there's the right results that occur about that test. That's how we protect the individual and the public health. That has to be done. We're still talking about the concept of contact tracing. I fear that people have taken this on much like they did after post 9/11 when everybody had their bottle of ciprofloxacin in the anthrax situation and said in Cipro we trust. You know, it's that kind of situation. Contact tracing has a ton of challenges to it about making it work and how it works. And we have time, we can go into those. And so that's not going to be a magic bullet. So you're looking to me saying, so what the hell are you going to do then, Mike? And that's our challenge. We are basically at this point, short of just not swapping air with people who might be infected, unknowingly infected, we don't have a lot of tools. And, you know, we can talk about masks, we can talk about all these things. Bottom line is that we have to start planning as if we're going to get through this without all the convenient ways of saying, well, that will be easy. This is a 4.7 hurricane potentially coming down the pike. Even if we don't have the big peak, even if we just have the slow burn, you've seen what this virus has done to our society. And let me just say that it's been a terribly unfortunate situation, and I have seen it front and center, how this virus has continued to divide our country and how it's divided communities. This virus has caused tremendous economic implications for people. I personally know that all too well in family and friends. So I don't want anybody to think that this is a bunch of public health people who just are making recommendation needlessly. We have to understand what it's doing to the community and how we address that, how we change with that, and what it means. But at the same time, you can't defy viral gravity. This thing's going to do what it's going to do. And it's not about public health's message. We're not the enemy. It's about the actual virus. And I think what we've tried to do at our center, I have a weekly podcast. We surely have a very active web-based presence. Just tell the truth, what we know and don't know, and what we're going to do to try to get through, and what we can say with certainty that works or doesn't work, and where do we go from here. My recommendations right now, just to give you some sense, I advise the American Council on Education, which is all the major college presidents. I'm actually, as a faculty member at the university, I also am a member of the Board of Regents of Luther College in Iowa. My message is go for it. Plan for the full fall. But you better have very detailed plans in your back pocket that you can stop in a dime and give back 9 cents change if you need to. That's how we should be approaching our lives right now. Go ahead. Let's try to plan for hopefully none of this materializes, but I know that we're going to end up having to do some real pivots over the months ahead. So with that, Chad, I will basically leave it behind, and happy to address any questions I can. And as I said, if I know the answer, I'll give you the reason why I know it. And if I don't know it, I'll tell you that and why I will keep trying to find out that information.
Great. Well, first question, I think a lot of people have heard from others who have said, back in January, I was sick, and now looking back, I wonder if that was actually COVID-19. Somebody in the chat is asking, is it possible that COVID-19 hit Minnesota before March?
First of all, COVID-19 was actually starting to spread around the world as early as November. We have confirmed cases now from samples that were collected, and that's not a surprise. When you look at global trade and travel, we knew that this virus was in Wuhan in mid-November. And again, this is the transportation hub for China. You don't go anywhere in China practically without going through Wuhan, whether it be from Beijing to Shanghai, Hong Kong, whatever. And same is true with air flights. So yes, we do have cases, but many of the people who thought they had cases have actually been tested by antibody and they're negative. They didn't have it. We have a lot of respiratory type agents that occur during the wintertime. Only about 20% at most are influenza. And there are a number of other viruses that sometimes can make you feel really bad. So was it widespread? Absolutely it was not, but we do have sporadic cases that are confirmed. And at this point, I'd say that, the most important message is it is now everywhere in the world.
Right. All right. Somebody was asking about, they have, one second here, it skipped on my, my questions here. Somebody says that they work with people with disabilities. Can they open their doors again in 2021, or is remote going to be the new normal?
Well, we will have a new normal. It doesn't matter what it is. It's just like air flight after 9/11. It was a new normal. The question is, can we ever go back to not having to be worried about masks, et cetera, et cetera? Right now, and this is, if you're contacted the health department, they tell you the same thing. Our evidence right now is we probably have the highest level of virus activity in Minneapolis, St. Paul, and potentially the St. Cloud area for certain, that we've had since this whole thing began. So it seems somewhat ironic that we're actually talking about releasing or relaxing the distancing issues. But again, this is a societal issue that public health is only one avenue of what we have to talk about. What is it doing to the rest of society? I would tell you right now, and this is what's really challenging, because you're looking at, example number one sitting on this side of the camera, and that is, if you're over 65, if you're a male, if you're overweight, particularly any age, if you have a BMI of more than 35, moderately obese, which 45% of our population is. If you've had underlying heart disease, you have hypertension, you have diabetes, you have renal disease, of which 790,000 Americans do today have end-stage renal disease. If you've had certain blood cancers or lung cancers, we're all at increased risk of, if we get infected, of actually having a serious illness and potentially dying. That's 40% of our state's population of adults. So that is a challenge. How do we keep from getting infected? And I think this is where we need to have really hard discussions. We've been trying to have this. As I talk about it, threading the needle with the rope. Put that rope through the needle. How do we get between those two guardrails? Can't let our healthcare systems crash and collapse. and people, by many people die. How do we keep from having a lockdown that's doing the devastating economic implications? And again, we're the first to tell you there are substantial health implications to this economic issue by themselves. People are going to, we're talking about the, many people in this country losing health insurance. We're talking about people in mental health issues, stress, the severity, on and on. So, but how do we navigate that in between? And that's the challenge we have right now, is how to have that discussion. I don't know how to tell you to bubble 40% of Minnesota's adults. I don't know how to tell you to do it. I can tell you right now that the face of this pandemic will change substantially over the course of the next several months. Right now, it's easy to dismiss who's becoming infected and dying. And I've heard this, painfully heard this. It's old people, long-term care facilities. It's prisoners, it's people who are in prison. People in drug treatment centers or homeless people. People who work in meatpacking plants, and we know who many of those people are. They're not from here. These have been painful issues, but let me just make it very clear. These are what we call congregate care or congregate work areas, where people are basically touching they're close by each other. And if you had only 1 out of every 500 people in this community that were infected, if one of those people goes to work at a nursing home or is a family member coming to visit somebody in that nursing home, it's like putting a match to a gas can. Whoosh, suddenly 40% of the entire facility is infected. And same thing is true in meat packing. Within the next 3 to 6 months, we're burning through those facilities so quickly, we're starting to get to 60 to 70% infected, or they've died. And the challenge is that in the next 6 months, that's not going to be the face of this pandemic. It's going to be you and me. It's going to be, this will continue to sweep through. I promise you this, I can say this with certainty, there won't be any blue states and red states as this really goes on. It'll be all COVID color states. And that's what people have to come to understand, that's going to happen.
Well, speaking about how, you talk at this point, we've had blue states and red states. We've had every country in the world that's been hit with this is finding their own way to deal with it. Somebody in the chat mentioned your thoughts on Sweden and their response. And I'd just like to open that up to what countries do you think are handling this the best and maybe handling it worst?
First of all, there's a lot of misinformation about what's out there. There is no Swedish model. That's a mistaken mythical belief. Sweden, which did, in fact, not put the kinds of distancing recommendations in place that was seen by others. On early March, they had the very same number of cases in Sweden per population as we saw in Denmark, Finland, and Norway. And people all said, look, they're all locking down, and Sweden's not. And in fact, I think I may have some data right here because somebody just asked me about this. Pardon me, old age here coming with the glasses. But let me just tell you right now, in the month of March into April, Sweden had an explosion of cases. In fact, they now have, if you look at a rate by deaths, they have a rate of about 32 per 100,000 cases. Persons living in Sweden have died out of their 3,313 deaths. That compares with the US rate. The second highest rate is 24.7. Sweden's had the highest rate of deaths in the world. And it's been largely due to the fact it's been what's happened inside their nursing homes and certain populations such as that. If you want to get an idea, since that time, cases have continued to grow gradually in Denmark, Norway, and Finland, where they grew rapidly in Sweden. Right now, Sweden's had 27,272 cases in their population of 10.3 million. If you look at Denmark, Norway, and Finland, remember Sweden had 32 deaths per 100,000 population. Denmark's now at 9, Norway's at 4, and Finland's at 5. That's very different than Sweden. Now, if you also look at the idea that Sweden says, well, you know what, we're going to get to this herd immunity. You know, we may have this now, but we're paying a price for it, but it'll be okay. And that's totally wrong. I have reviewed as recently as this past weekend the seroprevalence data, or the percentage of people in Sweden who are antibody positive having been infected. And it is not any different than we see in the United States right now. The highest rate I saw was for nurses and working in a COVID unit area that were in the high teens. Much of the population there is in the single digit positive. That's nowhere close to 60 to 70%. So we've had many examples come forward where people propose this, say this, and then it becomes a myth. It gets said enough times. The countries who have done it the best are unique. I think New Zealand has. If we only had 5 million people and lived on an island where we could greatly control who came in and out, and we didn't have early introduction of the virus into our place, I think we could control it too. Taiwan has actually done a fairly good job. But I advise the governments in Singapore, for example. I've had close contacts with Korea. I was in Korea working on the MERS outbreak that occurred there in 2015 at Samsung Medical Center when somebody brought it back from the Middle East. And all of them at one time or another had it under control. And then we've seen when Singapore, not recognizing the role of the migrant workers, had a massive explosion of cases, declared a state of national emergency. Same thing has happened in other countries. More specifically, look at Korea or look at China right now. There's an outbreak going on in Wuhan, and they're now back to trying to test all 11 million people in Wuhan this week because of the challenge. They've got major transmission in the virus in China right now, particularly in the northeastern corner of the country. And so this is what I call a leaky bucket virus. If there's one micro crack in this bucket full of virus, it'll find its way out. And that's what people have to understand. Nobody, unless you're an island and you can control everything in and out, completely control it, basically we're going to have a hard time. And I think that that's the challenge we've even seen in Europe. 3 weeks ago, the Germans were very confident they had really brought this under control. They relaxed their recommendations, and we've seen over the course of the last 2 weeks the numbers rise again in terms of what's happening there. But again, I come back and I just want to make this note. I actually hope I'm wrong, and for all the hopefully right reasons. I don't want to see cases disappear. Again, I hope the cases that stay are mild, nobody gets severely ill. But if we see a major reduction in cases, I promise you this is going to look like a flu situation in the months ahead, where we could have just one barn burning peak, which could be really, really devastating. So anybody continues to repeat the Swedish model also does really actually believe in the Wizard of Oz. And that's not a bad thing to believe in sometimes, but that's not helpful from a public health standpoint.
So how confident are you in Minnesota's preparation with a big wave of infections?
How confident am I in what will happen here?
Yeah, in Minnesota.
I'm concerned. We have nurses right now that are working in COVID units here that are reusing protective equipment they shouldn't have to reuse because we don't have enough. I mean, we have real challenges with making this equipment in a timely way. You know, even if you have a major company making 35 million of these masks, for example, a month, we have hospitals in New York City that were using 2 million masks a month just to do their work. Think about supply and demand and supply chains. You know, I have this piece that I mentioned coming out Thursday in Foreign Affairs. It's a lead article for the July issue of Foreign Affairs, but it'll be online on Thursday. And I wrote a piece in Foreign Affairs in 2005 about why we weren't ready for a pandemic and what we needed to do. Two things about that article were notable. One is we were a lot better prepared in 2005 than we are today because we had much more surge capacity. We have wrung all that out of our economy. We don't have surge capacity today. We've outsourced so much of our stuff to other countries, particularly China, and it just doesn't happen overnight where you can make this stuff. But the second piece of this is in terms of where we're at today, I actually took for my article the first paragraph of my 2005 piece and put it as the first paragraph of my this article coming out on Thursday. And if you didn't know, you would have never known it was written from 2005. We just have not understood the implications here. You know, the only reason you have invited me here today is because it's happening. If this hadn't been happening, there's no way in hell you would have cared to hear about from me. Nobody wanted to listen to the situation that it was coming, that we could do a lot to prepare for it. It'd be like ignoring the fact that hurricanes occur and category 5s do make landfall. And so one of the challenges we have today is how can we catch up? And I'll just tell you, we can't. We can only get better. But now is the time to prepare for the fact that what if in fact this is this big wave in the fall? If I'm wrong in saying that it could be a flu one, I'll be the happiest man in the world. But if I'm right and we don't do a better job even now of figuring out what we're trying to do, I can tell you it's going to be really not only physically devastating from a health standpoint, but it will be from a political standpoint, really a major challenge.
Great. You know, you mentioned face masks. Can you tell us a little bit about your thoughts on all the things that we're told to do? And initially it was, don't touch your face. Now people are recommended to wear face masks. What are these recommendations do you think are good? Are there any of them that you don't think are very effective? And is there something that we're not doing that we should be doing?
Well, let me just say that there are two lines of answers here. One is about the science-based answers. The other one's about the emotional-based answers. As humans, we all want to be able to do something to protect ourselves, our families, our communities, whatever. But you have to look at the science carefully here. First of all, the environment plays very, very little, if any role at all in the transmission of this. All this cleaning we're doing, all this hand washing, which, because I work in a lot of other infectious diseases, don't stop hand washing. It's really important, okay? But it's not having a big impact on what we're doing to prevent disease here. All this wiping down, et cetera, you know, the data are not there to support that this is a even minor way of transmission in terms of what goes on. But we do it because it makes us feel good and we can tell people to do it and it shows. You can watch people doing it and therefore, wow, that's good. The second thing is this masking issue. And this is a very, very real issue for me because it's all about healthcare workers at first. We now know, and I've spent my career working on influenza. I've been working on it for 40 years. We have come to understand completely that aerosols are a very critical way which influenza is transmitted. These are those little particles I talked about when you're talking. My office right now is filled. If you had the sunlight coming through the window, you'd see in this office all that dust. That's aerosols. And a lot of them are just from talking, not coughing, not sneezing, you know, none of that. And the challenge we have is that we have increasing data that shows that this is just like flu, that there is really a lot of virus we just put out that way. Well, an N95 respirator, the kind that the tight face-fitting mask that we use in healthcare, and we have to save it for them because we're otherwise already short. I asked for two different reasons. One is it's the material itself that you breathe through. And you breathe through this matrix material, which is actually a pore type material that actually allows air to pass through, but it traps the virus with electrostatic charge and holds it in there. Much like if you think of your Gore-Tex, you know, the rain stays out, but the perspiration gets out. And that's important. But you can actually achieve some of that same filtering with cloth masks, with just plain cloth mask. The problem is it's all about the fit. You know, unless you have a tight face fit, it's kind of like fixing 3 of the 5 screen doors in your submarine. You know, the air just goes in the sides. It takes the path of least resistance. So when you blow out or blow in, the air is just all there. Well, if I'm in a room full of this virus and aerosols, it's not the front part of the mask that's doing its job. It's the tight fit. And so I say if you don't have an N95, you're not protected. Can a cloth mask or a surgical mask reduce the likelihood? Well, let's look at it from two perspectives. If it's me I'm trying to protect myself, there are some limited data that says it may reduce the risk, but let me just make a point here. If you're walking across an intersection and a semi comes along at 50 miles an hour and hits you as you're walking across, that's not good. But if you're walking across that same intersection and a Ford pickup comes by and hits you at 50 miles an hour, that's not good either. So merely reducing the size didn't stop the outcome from happening that both did. And so all the data we would have say at this point that just masking of itself with a cloth mask or a surgical mask surely may reduce the number of particles you put out, big particles, or the big particles that get in, but it's the little particles that are coming along the sides that are the real problem. And so I'm telling you, you know, I would throw the kitchen sink at this thing if I thought that it would make a difference. Masks are not a major issue. And by the way, in 1918, there were actually some very exhaustive studies done on masks. After that, and John Barry, the historian who we work with closely, will tell you not one of them found that they made any difference. Number two is, just think about this, common sense. This is a group of common sense people here. The area of the world where geographically we had the highest frequency of mask wearing is just a social cultural event was in China, Hubei province, China, in November and December of last year. Did that mask wearing have any impact on that emergence of that horrible, horrible city on fire situation? I mean, that was one where we had virtually everyone wearing masks publicly. Didn't make a difference. And so I only say this because if you want to wear a mask, go ahead, feel free. I worry though that people who are at risk of having severe disease will take that mask and now assume a level of protection that they don't really have, and then put themselves in harm's way in a way that they wouldn't have otherwise. And so there's a downside to that. Finally, I just find the social political pressure, you know, today, if you don't wear a mask, oh my God, what a bad person you are. So, you know, and unfortunately, we've now come to make judgments, not on science, but on basically emotions. And I worry about that because this one's not kind of a big one. But what if we start saying, okay, all heavy people, we're going to do this to you because you're at risk of getting this disease more. Or all people who are of this age, we're going to do this to you because you're at higher risk. And they can say, well, you know, I'm using the same basis for making those recommendations that I made for the mask. Maybe it will help. And at some point, you just, I'm a scientist. I'm just a poor, lowly scientist. I'm just sitting here telling you, these are the data. You know, you make a decision how you decide. And I'm telling you right now that the masking is not an issue. Let me just conclude it by saying, my daughter is, and I'm incredibly proud of her, is the chief of the neonatal intensive care unit at the University of Minnesota. You know, amazing human. She took after her mother. And she's in there delivering babies from women right now who are severely ill with COVID disease. And that delivery room is swimming with virus. I can't tell you, swimming with virus. And I think about her as a mother of 3 kids, and if she doesn't have an N95 mask on, and even then, I can't tell you the fear I have of that. So at the same time, I would tell you exactly what I would tell my daughter. You know, it's either N95 or you don't have protection. And I think that's what I have to honestly tell people like you. If I want you not to get infected, that's it. So from a mask issue, I would just say, I can't make it any clearer than this. If you want to wear one, go ahead. But know that the science isn't there to say you're going to have a material impact on what happens with this pandemic.
And I know that you're short on time. You've only got a couple more minutes, but one thing I'd really like you to answer, we've got a lot of small business owners on the call, and some of them are starting to reopen those businesses. And after, you know, explaining that you don't think that a typical cloth mask is going to be very effective, what advice do you have for them on the proper steps of reopening?
You know, this is the challenge of this virus. I don't have a magic answer. I'm not trying to leave you hanging. I think we have to move on with life. I think that if you are at increased risk of having an adverse outcome, it's up to you. You have to take that risk. You know, we take the risk every day of driving to work. We take the risk every day of, you know, all the other health behaviors that we do or don't do. And at some point, you know, the original lockdown was with the idea of shaving the curve down so that we didn't overrun our ICUs. And, you know, I think we've done that. I've said over and over again, and I don't mean this in a trite way, we've had to painfully learn how to die by this virus. We also have to learn how to live with it. And I think that this is a discussion we need to have. I think small business people should be right at the table. You know, that's a very important point. I understand the pain. I actually have a very, very dear friend who is likely to lose his business over a 15-year business he's put together over this issue. Oh God, that's hard. So I think that this is the discussion we have. I will tell you, if we have the big peak situation, you'll be down again. Get prepared for it. You'll be down. At that point, no one will go out. There's no governor that'll have to make a proclamation. When it's all your family, friends, and colleagues that are dying, then it'll take on a very different picture. And I think that's, so I'm planning, like I said, on education, is move ahead. Let's go ahead. And just know, however, that right now this is a risk period. And I can't tell you what to do as a business person, but I would tell somebody who's at increased risk of having this disease, I wouldn't want to spend a lot of time around a lot of other people right now, particularly with the virus level we see in this city.
Well, thank you
So,
so much, Dr. Osterholm. We're at
thank you
your
all
time.
very much.
Parting words?
I wish you the best. You know, if I could leave you with one last piece of advice, and this is surely not meant to sound trite, but I have a weekly podcast that I do, and this has come to mean a lot. So I say this in talks. You know, the one thing that we can do to counteract this pandemic of COVID is create an epidemic of kindness. And, you know, I think if everybody on this call or on this phone will just once a day, just consciously do something kind to people, you know, that surely would help. It won't take the virus away, but it will at least give us a different direction to think about where we're going. So go for it. Thank you very much. Bye.
All right. Thank you. And thanks everyone for being on the call today. We've got our start of our 5-part Economic Development Summit starting on Thursday. We'll send information out about that. We also have a social media virtual meeting next Wednesday for all of you who are really trying to hone up your skills on social media. It's becoming more important now than ever during this pandemic. So please tune into that. We have a specialist from the State Fair. With that, I will say thank you for attending. Look for the link coming out later today. Goodbye.